Our next speaker, he is not going to come as a live, he will be playing a recorded session of his. We are going to talk on longevity, and in longevity session, our next speaker is Dr. Chad Larson. Dr. Larson is both certified in both naturopathic medicine and chiropractic. His practice integrates naturopathic medicine with cutting-edge laboratory testing and diagnostic imaging. This integrative approach to medicine includes diet and nutritional counseling, prolotherapy, regenerative injection therapy, chiropractic, manipulative therapy, bioidentical hormone balancing, intravenous nutritional therapy, and natural alternatives to prescription drugs. His topic for today is cardiometabolic and gut health connection. Let us hear what he has to say on his session.
Hi, I'm Dr. Chad Larson. Thank you for allowing me to present this webinar to you. So here are the learning objectives. We want to first review the latest statistics of cardiometabolic syndrome, because unfortunately, although this has already been a very important and increasingly worsening condition, it seems to be getting even worse over time, and more individuals are suffering from this important condition. The second objective is to review the association between the intestinal microbiome and the integrity of the intestinal barrier. Then we'll discuss and review the association between the integrity of the intestinal barrier, inflammation, and the onset of cardiometabolic disease. And then finally, we'll discuss diagnostic concepts for endotoxemia and intestinal barrier dysfunction, because it's important to understand how we can identify these important issues in our patients. So this was a study that was published a few years ago, and this is a statistic that I've been using ever since. And unfortunately, there are more recent data that unfortunately the situation has gotten worse. But back in 2019, they published a study that indicated only 12% of US adults are metabolically healthy. That means the vast majority of US adults are metabolically unhealthy. And that includes, this particular study included all the way down to 20-year-olds. So that means that even very young adults are suffering some of these cardiometabolic effects that the older adults are as well. There's been a new report, and the statistics unfortunately have gotten a little bit worse, actually significantly worse. Now, the health of the US adults is only 6.8%. And so only 6.8, less than 7% of adults in the US have cardiometabolic health. That means the vast majority, almost 93% of the US adults have cardiometabolic issues. And this is a major problem, because as we'll discuss, these cardiometabolic issues are what are generally plaguing our society today. And medically, they're not being treated the way that they really need to be. So again, from that study back in 2019, here's what the researchers suggested. Currently available interventions to improve health-related behaviors have met with limited success, and stronger and more widely accessible strategies to promote healthier lifestyles are urgently warranted. And unfortunately, those have not been warranted, and the statistics have gotten even worse. So this trend of cardiometabolic illness has dramatically increased, and we are becoming more and more cardiometabolically unhealthy. And so what's the problem with that? How does this manifest in our body, and how does it lead to issues? So we'll discuss a little bit more about the how metabolic syndrome is diagnosed, but here's what it really manifests to from a symptom and condition standpoint. This is generally how metabolic syndrome is diagnosed. These are the criteria. A person only needs to have 3 out of the following 5 criteria to be diagnosed with metabolic syndrome: blood pressure higher than 130/85, a fasting blood sugar over 100, a waist circumference greater than 40 inches in men and 35 inches in women, a low HDL cholesterol, under 40 for men, under 50 for women, and triglycerides over 150. So these are very, very routine, easy measurements to evaluate. But what's different about calling this metabolic syndrome in our standard, sort of medical care is that each of these things is addressed as separate conditions and treated separately. And the important connection between all these is typically not made. So we're not getting to the real root underlying cause of why these things are manifesting in the first place. So these particular statistics, or not statistics, but measurements, is what was used in that study that I mentioned. And any of these studies that I mentioned, I provide the PMID for that. So if you wanted to read the full study, you can just type in that PMID and you'll get the full text of the study. So those are the criteria that were used in the study that I cited, with only less than 7% of the US adults being cardiometabolically healthy. So the idea that this is a big deal, this is affecting the vast majority of the citizens, and it's something that as healthcare providers, we really need to figure out how to address. And for those of us who practice functional medicine, I think we're uniquely suited in order to help these patients, because like I said, with the standard medical system, these things are being treated individually and not very successfully. And what we need to do is consider the connection and what binds and ties these different seemingly disparate symptoms and conditions, actually tie them together into one particular syndrome. And what it comes down to is this very important symbiotic relationship between our intestinal microbiome and our gut cells, and how that influences really the rest of our health, the rest of our bodies. So our bodies use this important short chain fatty acid called butyrate. We get this from certain beneficial microbes in the intestinal tract, and butyrate gets beta oxidized by the gut cells, and this uses oxygen. And this process using oxygen has a net oxygen lowering effect in the gut lumen. The gut lumen is healthiest when it's in an anaerobic state. And so butyrate being beta oxidized using oxygen helps to maintain that low oxygen state in the gut lumen. This is what happens in a healthy gut response. Butyrate, this important short chain fatty acid that's produced by the beneficial microbes, also has a couple other important aspects. It also helps to support and sort of upregulate regulatory T cells. The Tregs, or the regulatory T cells, are very important for our immune system balance. The fact that we're able to tolerate non-self antigens like dietary proteins is because regulatory T cells explain to the immune system that these are okay and we don't have sensitivities. However, in an unhealthy situation, regulatory T cells are diminished and they're downregulated. And then our immune system can become more hyperreactive to non-self antigens like dietary proteins. And we become sensitive to these foods. This is one way that we can develop food sensitivities. Also, what butyrate does is it binds to PPAR gamma, and that has a beneficial effect on decreasing inducible nitric oxide synthase. That then reduces nitric oxide, and that reduces nitrate levels in the gut lumen. And let's see what happens when all this goes in an unhealthy direction. If we have dysbiosis, if we have imbalance of the healthy and unhealthy bacteria in the gut lumen, we're going to have a net decrease or insufficiency of butyrate. If we don't have enough butyrate, we have downregulation of regulatory T cells, and that can cause a net hyperactive immune response or dysfunctional immune response. We also don't have the effect on PPAR gamma. So nitric oxide synthase increases, nitric oxide increases, and that leads to too many nitrates. And then pathogenic bacteria will use those nitrates to proliferate in the gut lumen, and that's going to promote even more of a dysbiotic environment. And also because this is not happening through beta oxidation like it is in the healthy situation, then the oxygen that would be used up via beta oxidation is rising then in the gut lumen. And that's creating a aerobic environment. And that's going to promote, again, more pathogenic bacteria to promote in the gut lumen, leading to dysbiosis. And then dysbiosis eventually could then lead to leaky gut, because it's these dysbiotic substances that can then break down the integrity of the gut barrier. And then that has influence inside the gut. When that gut bacteria releases the endotoxins, which we'll talk a lot more about in a couple minutes, these endotoxins then can influence things like GLP-1. And there are, GLP-1 agonist medications that are supposed to be used for things like, blood sugar dysregulation and diabetes. Some of these GLP-1 agonists are like Trulicity and Byetta and Ozempic, and these other medications that are becoming very, very popular, especially in the US, are being used because of this whole cascade of effects. But if we can improve the function of the intestinal microbiome and improve the function of the intestinal barrier, then we can actually upregulate our very own GLP-1. And that's going to have significant influence on things like our blood sugar metabolism. Because we see in an unhealthy situation, there's inflammation from the endotoxins on the liver, on fat cells. It's going to influence the pancreas, and it's going to decrease our blood glucose and insulin sensitivity, and it's going to contribute to inflammation, which can even influence the and lead to neural inflammation and neural degeneration. So we're going to talk sort of macroscopically about these conditions of cardiometabolic syndrome, but we can understand from a microscopic standpoint, this is where a lot of things start to really have an issue. So this slide kind of tells a lot about this whole connection between the integrity of the gut barrier and the onset of these inflammatory cardiometabolic issues. So what is endotoxemia? So it's endotoxin in the bloodstream. And so let's talk some more about what we mean by endotoxin. So these endotoxins are produced by certain gram-negative bacteria. And these gram-negative bacteria, these are things like Campylobacter jejuni, Klebsiella, Salmonella, Shigella, Helicobacter pylori. There's a bunch of these gram-negative bacteria, and they produce this endotoxin called lipopolysaccharides, LPS. And the toxic component of LPS is this lipid A component. It's a so-called PAMP, or pathogen-associated molecular pattern. And this is what instigates a cascade of inflammation when LPS binds to its receptor called TLR4. We'll discuss that a little bit more on the next slide. But this is what causes the endotoxin. LPS is supposed to stay in the gut, and it's dealt with in the gastrointestinal tract when things are healthy. But when we are in a dysbiotic situation in the gut microbes, that's going to eventually break down the integrity of the gut barrier. And then we're going to get endotoxemia, which is this endotoxin slipping through the barrier system and getting into our circulation. So LPS, lipopolysaccharides, via the lipopolysaccharide binding protein, binds to toll-like receptor 4, and via a bunch of specific adapter molecules, they activate a bunch of different transcription factors, and this eventually leads to a significant increase in these inflammatory substances, TNF-alpha, interleukin 6, cyclooxygenase 2. These are all pro-inflammatory substances. So I just wanted to make the connection between LPS binding and then causing this whole cascade of molecular effects that eventually results in an excessive amount of inflammation. So just remind you, this is all taking place inside the gut lumen, and there are 4 main layers to the gastrointestinal tract. We have the serosa on the outside, and then we have the muscularis, which obviously controls things like peristalsis. And then inside that, we have the submucosa. And then on the very inner component, we have the mucosa. And so again, just to remind you, the gut is a tube. And if we take a little snippet of this tube and we magnify it, we have these large villi, and we have these crypts here on the inside. And if we take a component of this and we blow it up, then here we could see one of these villi that are rich with blood vessels, waiting for substances to be absorbed from inside the gut to get into the circulation superhighway to be delivered all over the system. But as we'll look in just a moment, when there's a breakdown of this barrier system, then inflammatory substances could reach the circulation. And that's how inflammation can be propagated all throughout the system. So this is another schematic showing the difference between a healthy gut barrier and an unhealthy gut barrier. Here, we see these 2 gut cells are tied together by this tight junction, and this is preventing substances from getting through into the circulation. But when things go wrong, we have disruption of the tight junctions, and we can have these inflammatory substances. Now they can pass through the gut barrier, get in through the submucosa and into our circulation. And once they reach the circulatory system, then they can, they can be distributed throughout the whole system. So this is how leaky gut can really influence systemic inflammation. This is saying a similar thing. Over here, we have a healthy gut. We've got the gut lumen up here. We've got this important mucosal layer, which is another component to the protection of these cells down lower. Then we have the intestinal epithelial cells, and they're all we've got a tight junction right here to prevent substances up in the gut lumen from penetrating all the way down to the bloodstream. However, when there's leaky gut and there's breakdown of the intestinal barrier, then we have opening of the tight junctions. This particular schematic is showing the paracellular route, which is right down through the epithelial cells. On the prior side, we also showed the transcellular route, which is right down through the epithelial cells. So here we can see that once there's breakdown of the paracellular pathway, then a lot of these substances that should stay in the gut lumen now can pass through and lead to endotoxemia, which is when LPS passes through the gut barrier and gets into the circulation. So in this study, they concluded that our findings demonstrate that circulating serum LPS is higher in type 2 diabetes than in lean, healthy subjects. Second, LPS can activate the innate immune pathways in isolated fat cells to stimulate secretion of pro-inflammatory cytokines. These observations, taken together with the finding of increased expression of innate immune system pathway factors in adipose tissue taken from obese and type 2 diabetes patients, suggests a role for LPS in initiating the clinical inflammation seen in these states. So it's been known that states of obesity and type 2 diabetes is associated with inflammation, but now we're understanding that at least one of the causes of this type of pro-inflammatory response is from LPS getting from the gut into the circulation because of breakdown of the intestinal barrier. There are multiple insults to the integrity of the gut barrier. There's lots of things that can cause leaky gut. And this is a purposely sort of, disorganized looking slide, because this is the chaos that happens at the gastrointestinal tract. Here's another study connecting the role of endotoxemia to systemic inflammation. While the cytokine storm triggered by the release of large amounts of LPS can lead to shock and potentially organ failure, the long-term effects of low-grade endotoxemia are associated with an increased risk for cardiovascular disease and type 2 diabetes driven by meta-inflammation. Because it wasn't too long ago, probably just a decade ago, that only sepsis explained LPS and these endotoxins in the blood. But now we're understanding it could actually be a spectrum. There could be a lower end of that sepsis spectrum, and it could be chronic. And this is what can lead to this chronic amount of inflammation in the system. This study also made a similar connection. This review provides supporting evidence of mechanistic associations with cell and animal models, and provides complementary evidence of clinical relevance of metabolic endotoxemia in obesity as it relates to inflammation and metabolic derangements in humans. This study, titled Endotoxemia, Nutrition, and Cardiometabolic Disorders, also emphasized that high lipopolysaccharides was significantly associated with prevalent obesity, metabolic syndrome, diabetes, and coronary heart disease events, independently of established risk factors, CRP, and total energy and nutrient intake. There were some unfortunate studies that indicated that a high-fat diet was the cause of leaky gut and endotoxemia, but it actually didn't describe the whole situation and the whole picture. And so that was the point of this study, was to very explicitly explain that it's not just from total energy intake. And when they factored for that, taking out a high energy intake diet like a high fat diet, there were independent factors. High LPS was significantly associated with the prevalence of this type of inflammation, even by accounting for total energy intake. So I just wanted to put this study in there, because if you start digging into the literature, you'll see some of those earlier studies that seem to blame this on a high fat diet. But it's what we can find from the study is that metabolic endotoxemia is more substantive in patients with chronic metabolic disorders, and that can be independent of a high fat diet. Metabolic endotoxin activity in human serum is associated with dyslipidemia, insulin resistance, obesity, and chronic inflammation. So high serum LPS activity is strongly associated with components of metabolic syndrome. Bacterial endotoxins may thus play an important role in the development of metabolic and vascular abnormalities commonly seen in obesity and diabetes-related diseases. This is a study that is particularly upsetting because this cardiometabolic effect, and one of its very common associations, non-alcoholic fatty liver disease, NAFLD, is now even creeping down into the pediatric population. So in this study, by adjusting for BMI, insulin resistance, and inflammatory marker CRP, we found that an elevation of endotoxin appears to be strongly related to the presence of hepatic steatosis. Both endotoxin and its resultant inflammatory perturbation appear to trigger hepatic and peripheral insulin resistance. So NAFLD is a very, very increasing chronic liver disease. It's the number one in the Western world, and it's increasing pretty exponentially all across the globe. And this connection with cardiometabolic syndrome and insulin resistance and endotoxemia are really, 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 really important. And this is a cultural failure, in my opinion. And this isn't just an adult issue. This is now creeping down into the pediatric population. And it's a very, very important thing this could literally change the rest of their health by dealing with NAFLD as a kid. I mean, they're just set up for poor health the rest of their life. This one went on to explain, we observed that adolescents with NAFLD, mostly NASH, which is even worse, had elevated postprandial endotoxin compared to healthy individuals. So again, back to this, the end result of this sort of dysbiosis, breakdown of the intestinal barrier, if we don't have enough healthy bacteria, we're not going to produce enough of this very important symbiotic substance called butyrate produced by the healthy bacteria. And if we don't have enough butyrate, that's going to influence our immune system activation. That's going to influence the oxygen and nitrate levels in the gut lumen, which are going to further promote more pathogenic bacteria. And then GLP-1 goes down. If GLP-1 goes down, that's going to lead to a decrease of insulin sensitivity, an increase of inflammation, and this inflammation can even infiltrate the brain. And we know that it could cause systemic inflammation throughout the body. So a question you might be having is, can we detect this in our patients? And if so, how do we do that? What are the markers that we could evaluate to indicate this type of endotoxemia and disruption of the intestinal barrier? So here's an example of some markers. So let me just orient you here. We have several markers: actomyosin, we have occludin and zonulin, and then we have lipopolysaccharides. And this is an example of early onset gut dysbiosis. We could say early onset because it's an IgM mediated response reacting to LPS. IgM, as you'll recall, is part of the early phase of our immune system reactivity, and that's the dominant antibody. And what this result is showing is that lipopolysaccharides is starting to break down the integrity of the intestinal barrier. As you may know, occludin and zonulin are involved in the tight junction of the intestinal barrier. So that being elevated indicates some early onset tight junction compromise. But we can see that IgG is starting to increase. If this starts to persist, this can become a real chronic issue. This one is an example of early onset gut dysbiosis and an intact intestinal barrier. So we're seeing LPS go up, but so far there's healthy gut barrier. So this is an ideal stage. If we can catch a patient here, we can treat for the dysbiosis even before it starts to break down the integrity of the gut barrier. This is an example of long-term reactivating gut dysbiosis with an intestinal barrier intact. And we have IgG reacting, but we're starting to see some reactivation. IgM is probably starting to go up here. So we're seeing all three components, IgG, IgA, IgM, all reacted to LPS. So this is a really significant dysbiotic situation. It's probably leading to some endotoxemia, but there's not significant breakdown of the intestinal barrier yet. This is a condition of epithelial cell damage. The actomyosin represents the integrity of the epithelial cells and the so-called transcellular pathway. The occludin and zonulin markers represent the tight junction and the paracellular pathway. And then, of course, the lipopolysaccharides lets us know if there's intestinal dysbiosis. So this is a fairly chronic case. This is, a fairly common finding in people who have these cardiometabolic issues. We oftentimes find that they have significant compromise to their intestinal barrier, and they're already well on their way into endotoxemia. So this just represents the gut barrier. We have this very important mucosal barrier on top. And this mucosal barrier is really, influenced by even things like hydration, but of course, a healthy intestinal microbiome. And then the next layer down, we have the secretory immunoglobulin A, or the SIG-A. The secretory immunoglobulin A is like a barricade trying to prevent these pathogenic substances from getting all the way down to the gut barrier. And so we have several layers of protection before a pathogen can get all the way down to the circulatory system. But as we've discussed, this whole barrier mechanism could all be compromised syndrome. So I hope that was helpful. Hopefully you learned something. I appreciate you listening, and we'll talk to you next time. Thank you very much.